Welcome to Rapcast, the official podcast of Rheumatology Advanced Practice Providers. I'm your host, Amanda Mixon, president of RAP, and I'm delighted to welcome you to this episode in our 2026 Fireside Chat series. Today's conversation is titled Inflammation Intersections, a Rheum-Gi dialogue. In rheumatology, we know that inflammation rarely respects specialty boundaries. Many of the conditions we manage extend well beyond the joints, often intersecting with the GI tract in complex and clinically meaningful ways. Understanding these overlaps is critical not only for accurate diagnoses, but also for coordinated patient care just in general, as well as really how we make our treatment decisions. I'm thrilled to be joined by two outstanding colleagues who bring complementary perspectives to this discussion. Kim Orleck is a GIPA and a board member of GAP, and Wendy Simmons is a rheumatology PA and RAP board member. Together, we're going to explore where rheumatology and GI intersect, what these shared inflammatory pathways mean for our patients, and how collaboration across specialties can improve outcomes at the point of care. Whether you practice in rheumatology, gastroenterology, or alongside multidisciplinary teams, this conversation is designed to offer practical insights that you can take back to the clinic. So let's just go ahead and dive right in. So let's start by kind of going over the overlap between GI and rheumatology. So Kim, again, welcome to Rapcast. We're so excited that you're here. Patients with one autoimmune disease often develop another. It's not uncommon for patients to come in and say, I'm dealing with this, or I have a lupus patient and they also have Hashimoto's, or even MS or Sjogren's or various things. So we obviously know this to be true, but how do you recognize and monitor for cross-specialty IMIDs early, and how does this impact your treatment planning from the start?
Yeah, first off, thank you for having me, and such a great topic and such a great question. So I think the first thing, when I see these patients, particularly with IBD being the most common one with this immune-mediated overlap, I think of the fact that there's patients with IBD up to 50% who have what we call that extraintestinal manifestation. And so that certainly can affect the joints. It can also affect the skin, the eyes, hepatobiliary, and other organs. Then there's what we call these immune-mediated comorbidities. So as you mentioned, patients with one autoimmune disease are more susceptible to having another, the thyroid examples you gave, the diabetes, etc. So first, obviously, comes to taking that really great history, right? And making sure we understand if patients have been diagnosed with any of these other autoimmune conditions. And if they haven't, I know for me, it's really asking all the questions to see if they do have any other symptoms that have not yet been diagnosed, whether it's an associated immune-mediated condition or an extraintestinal manifestation. And I know we're going to talk a lot about this, but it's so important because when I start to think about therapy for these IBD patients, we want to make sure we're choosing a therapy that if they have other autoimmune conditions, extraintestinal manifestations, we can treat all of those ideally with one therapy instead of having to do multiple different therapies to treat these overlapping conditions.
Wow, I had no idea it was up to 50% had
Yeah.
extra GI manifestations. Wow. Wendy, welcome to
Yeah,
Rapcast again.
thank you. Thank you for having me. I agree. It's nice to be on this panel as well with you, Kim. And I could not certainly agree more from the room side as far as how important that history is that we do take now. It's not just our rheumatological disease specific history. I feel now that we know, time, look in the past history, childhood rashes, joint pain, and then also that family history becomes very important as well. I feel that now we're seeing this crossover as well and sharing, because as we know, there are different buckets of autoimmune diseases. They travel in packs. What one family member has doesn't necessarily mean that next family member will have. And now with this wonderful, crossover with Rheum and GI, we're actually seeing that in our patients, which makes it easier. And then also that social history, you mentioned comorbidities, smoking being so important as well. So I agree that helps us to focus on what is in front of us, but also to have that documentation. So if that patient does circle around or you send me that patient from GI, I have that history.
Absolutely. I would just echo that too. I feel like it's so important that we always ask those right questions. And it's really kind of understanding that there's really a link between all of these conditions. So that's going to get me to my next question. So, Wendy, when we're thinking about this link between Crohn's and ulcerative colitis,
Mhm.
psoriatic arthritis, ankylosing spondylitis, how does really understanding that there's these shared pathways kind of guide our therapy decisions?
Absolutely. Well, you know, I feel that the understanding for all of us and everyone listening is to understand that these are linked by shared access, that gut, joint, skin. We know that there's genetic predisposition. We know we've talked a lot about in the past HLA genetic markers. These are combined, triggered by environmental potentially, also smoking, things like that. And then I think to remember that we've got the macrophages, the dendritic cells that actually at that point really produce that IL-23 that is then, really getting dysregulated in this pathway. We know that IL-23 then keeps those the helper cells 17 surviving. We know that those then are responsible for producing those pro-inflammatory cytokines, the IL-17s, 22s, TNFs that all go to the gut, the skin, the joints. So I think if we remember all that, that certainly helps us as far as mechanism of action and, what is actually now linking them. And it makes sense to us because of that pathway.
Absolutely. Kim, do you have anything else to add when you're kind of thinking about
Yeah, I
this?
mean, I think Wendy summarized it great. I think particularly about this, she mentioned it like it's the gut joint axis, right? And we know that the immunologic mechanisms connecting them, you mentioned a few of the big ones, Wendy, but IL-23 through IL-17 leading to TNF axis, right? And, I know we'll talk about how do we choose meds based on this, but just remembering that this increased cytokine production and overexpression that we see, for example, with TNF, is overexpressed in all these conditions. So again, it's just important to remember as we talk about meds and therapies, the shared pathways between these diseases, all going back to that gut joint axis.
Kim, I've been reading as well and learning about the microbiome and how important that is and
Yeah.
how that can really contribute to the joint inflammation. And for me, that's been opening up a lot of understanding and helping me
Yeah.
as we just talked about in the previous question, going back to that history. So I guess in your GI patients, you pay attention to that as well.
Yeah, I think it's so interesting, Wendy, because to your point, it's like we know that patients with AS, with psoriatic arthritis, with IBD, we know there's this altered gut microbiota, right? This dysbiosis. And we know that this is characterized by this increase in pro-inflammatory bacteria. And that often leads to triggering the systemic inflammatory response
Mhm.
and leads to intestinal barrier breakdown. I think the hard part is we don't have a ton of data of what that means in terms of treatment, right? You'd think like the easy answer is, hey, let's put a patient on a probiotic. But then when we look at the data for kind of probiotics and helping with dysbiosis and having data in IBD, it's not quite there yet. So I think it's important we remember that, yes, there's a role that overlaps with all these conditions of microbiota dysbiosis. But again, we don't necessarily know what that means for the therapy part.
That helps me so much because I've never really understood about the probiotics and all my patients coming in telling me I'm starting them or what do I think? So now I have that information. Thank you.
Well, yeah, we just don't have, and I think part of it when you like look at the literature in GI is we have some evidence in pouchitis, particularly. So patients who have had a colectomy and have a J pouch, there's some evidence there for probiotics. But when we look at most other conditions, including IBD and GI, we don't have a great recommendation that says, hey, a probiotic works. And part of it is there's so many different probiotics and different microbiome getting put in them, and we don't necessarily know, again, how we move the needle with that therapy.
Super interesting. I mean, this is really where kind of we get more into like the future with precision. And, I think we're gonna be there, sooner rather than later, which is so, so exciting. And, we've really kind of shifted how in rheumatology, when we manage some of these spondyloarthropathies, to be really more of a what we call kind of a domain-based approach. So do they have to what you already mentioned, the eyes? Do they have the skin? Do they have the gut? Kim, when you're looking at a therapy, right? So, how do you approach it when you're choosing a medication like, I don't know, upadacitinib or risankizumab? which are both approved in rheumatology and GI diseases?
So really a great question. I think this is kind of one of the hot topics. I'm sure you guys have this in room too, but an IBD is kind of like which therapy do we go to when? So one of the things I think about if in this question we're really looking at kind of UPA or JAK versus RIZA or IL-23 is the severity of my patient's disease. And so if this patient has really severe IBD and I'm trying to keep them out of the hospital, I need something that's going to work really fast. This is where I often turn to UPA. And what we see in IBD, particularly with ulcerative colitis, but also with Crohn's, is just the rapidity of onset for these patients having relief of symptoms and even endoscopic healing. So yeah, if there's that patient that really has this severe IBD for the rapidity of onset, I'm typically more turning to UPA. Obviously factoring in, and I'm sure we'll talk about this, but their cardiovascular risk is certainly something I think about. The other time that I would favor UPA is also a patient that has low albumin, just knowing that these small molecules are going to work better in that patient compared to our biologics, where often it's hard to really get their drug levels good enough if they have low albumin levels with these biologics. So overall, I think about their severity of the disease, how fast I need to get their GI symptoms under control, and then factoring in their extraintestinal manifestations. As you mentioned, in this condition, we could kind of turn to either, but also thinking about their past medical history, their family history, their comorbidities. Are they smokers, higher cardiovascular risk, and things of that situation?
I have to say I didn't know that UPA worked that fast in the gut. That's actually super helpful.
Mhm.
Um, Wendy, do you have anything to add?
Yeah, so that's just so interesting as well, and it does help us because now we are sharing more patients with you as well. And I feel, and I agree with what you said as well, Kim. Looking for what is that dominant symptom? What is that main symptom disease point that you need to get under control quickly? And with the patients, if there's axial involvement as AS patient or they've got axial SPA, I tend towards upadacitabine. I go there. I feel that my patients that I have are doing well. They continue to do well, and it does work relatively quick with those as well. So I like that. I have recently shared some patients from GI. One patient, which does speak to what we talked to about getting that history, years ago, um, had some mild joint pain, but I never did anything. But I did find she had UC. I didn't know that at the time, referred her to GI. They diagnosed her. She had been years on infliximab and then cycled through some biosimilars and completely controlled gut. The GI conversation I had was that they had biopsied her. There was no microscopic evidence, but she had broken out with severe scalp psoriasis. And she did have some dactylitis and enthesitis. And in that patient, I did have the conversations with GI, and GI was like, "Oh, you treat her." Of course, we talked about dosing, but she seemed to respond, initially with Riz. So I went there. So again, I agree. I think we tend to look at least on the room side, if there's anything where there's gut, I talk to GI.
Yeah, and I totally agree just to kind of echo that. So if patient has axial disease with their IBD, I agree with you. I'm going for UPA. Um, and then typically if they do have some sort of psoriasis, I typically am going more with the IL-23, particularly if it's a patient again who's not quite as severe. I don't need that relief kind of in days. I have a little bit more time to get them under control. And TNF induced psoriasis, I typically am turning to the 23s. And as you mentioned, Wendy, I've had great results with that and also kind of partnering with Rheum and or Derm, whoever is also caring for that
That
patient.
is awesome. That is awesome. And of course I do look sometimes at, well, what have they been on in the past? That definitely could have a
Yeah.
bearing on my choices as well. And then comorbidities and safety in there as well. A lot of conversations.
Yeah, and you mentioned, right, in IBD, it's very similar. Like there are certain therapies we know tend to do better, even if it's second line in a patient who's had a prior exposure, right? Now, when we talk about the IL-23s and the JAKs here, UPA, thankfully, both of these do fairly well for us second line with some kind of caveats when we look at Crohn's versus UC. But I think to your point, there's just so many things we're thinking about as we kind of reach to what's our next medical tool that we're going to talk to our patient about.
Right. I really also like being able to talk with the GI colleagues because obviously it was their patient. Then the patient had the skin, the joint. And so our dosing is shared but different. So those conversations, we certainly have as well, I think, for guidance. And then I try to document everything because I know the insurance will be looking at my note as well, just to see where we're going to be able to get the approval and who's going to prescribe and treat.
And I think that's so important. I mentioned, in GI, I think we're kind of known for being a little bit more aggressive. But I think the dosing is really important. And I try and take onus to being the one to prescribe often because
Mhm.
GI dosing is higher. And we know, particularly these IBD patients, they have such a high inflammatory burden that we really want to treat them aggressively. So I think having that communication between providers and different specialties is super important. But also, often, I think GI or whoever has the highest approved dose really wants to own treating that patient.
You are wonderful because that's exactly what I think that we need to hear here in room because our
Yeah.
doses are lower and then you have the loading and higher. And then here I'm so worried that, well, I know I'm comfortable with the scalp psoriasis, the dactylitis, enthesitis, but I'm thinking, oh my goodness, starting at my dose, is this gut going to unleash? So I
Yeah.
really do appreciate that. That
Yeah.
is just wonderful information.
And again, when we talked like rapidity of onset of JAK, like when we use UPA and I feel like yellow gas, but like we start at 45,
Yeah.
right?
Mhm.
Yeah.
And it's 8 or 12 weeks at 45, depending on Crohn's or UC, but often we have to do even off-label extended dose of 45. And we don't really flinch at that because that's often what our patients need to really get their disease under control.
Yeah, no, that's so interesting, and again, this I think is why it's so important that we all talk to each other, because when I try to prescribe it, to your point, if I do have a patient with the inflammatory arthritis piece, but then they also have the IBD, often insurance won't cover that dose. So it's just so important that we cross collaborate all of the time with each other. So Wendy, this is a little question for you, but what advantages, on that same note, do cross indication therapies offer when a patient has both good joint and gut involvement? Or is it potentially a risk for developing another IMID in the
Oh,
future?
exactly. I mean, that's something that we certainly are always going to worry about. I think going back to like the dosing as well, I know just being sure that you're treating that patient appropriately, because we don't always know those exact answers, for that as well.
Absolutely. So, when you're selecting a first line therapy for a patient with joint symptoms, GI symptoms, or risk factors for developing another IMID, how do you weigh disease severity, comorbidities, family history, early GI warning
Yeah, yeah.
symptoms, and the benefits of choosing a cross indication therapy like an IL-23? Can you do that in about 30 seconds,
You
Wendy? No.
know, I look at the toolbox and I think now we have different sections of the toolbox. Basically, again, looking at what that prominent disease is showing us now that we have to immediately get under control. But you're right, in 30 seconds, just really you've got to think quickly about it, the comorbidities. You've got to think about, safety, what they've been on before. And sometimes you have to have those deep conversations with that patient to be able to get that disease under control. I look at it like a 5-lane highway, and now we've got all those different classes of medications in there. Well, some of those lanes on the highway don't even cover what we're looking at here. So we are getting a little bit more well defined as to which direction that we can go in.
Kim, what about you?
Yeah, I mean, I think again, 30 seconds, none of us can do it. But I think in my brain, it's kind of thinking about that patient sitting in front of me. For me, the severity of their IBD, what their associated inflammatory conditions are or extraintestinal manifestations. And then I kind of cross out what meds aren't going to cover that, right? Because my goal is to kind of find that blanket treatment that hopefully is going to cover multiple autoimmune, multiple EIMs if they have them, so that ideally we can put them on less therapy, and really treat all of their autoimmune inflammatory conditions.
The uniqueness of all of this, the domains can change and that patient can come back and, something that we might not have realized at first, I think can make it a little more difficult.
Well, so then how do you approach screening to identify these risk factors, Wendy?
So definitely back to that history for sure. Not relying on that patient to pop it up. And I just had a lady a couple of weeks ago that she's in current evaluation right now. And, during this history, I was able to get out that she thought, oh yeah, I think I was diagnosed with UC years ago and I had a colonoscopy. She had not had a follow-up. So what I gave her to take control of until she comes back in a couple weeks for our visit is to go get the colonoscopy report. And I do that a lot now, is to see if they've been to GI and just try to get what information you all have. I think you all do great notes in GI, but getting pieces, extra pieces, Amanda, like colonoscopy report helps so much to get that into your chart.
I just wanna add to that too, because I think it's so important just to remember that there's often this, like, subclinical gut inflammation in the patients you guys are seeing, right, who have known joint disease. So I love the fact that you're really just asking these patients that, have they been diagnosed? Have they had a colonoscopy that's ever showed anything? And I think for us in GI, equally as important, right, it's checking their meds and seeing, are they being treated for another autoimmune inflammatory condition, checking their past medical history. I know, Wendy, you asked about family history too, and I think that's so important to get not only the risk of therapy, but what else might they develop, be it family history of thyroid or other immune-mediated conditions. And then I know we'll talk about this, but I think there's such an importance of these biomarkers, right? And it's hard because all these inflammatory conditions can cause, changes to biomarkers. And how do we in GI figure out if GI is driving that or is Rheum driving that? Again, going back to the importance of the partnership across specialties.
Something else I also do is a little pearl is I do it at every visit. I really now just add in, have you had any changes in your gut? Have you had any changes with your skin? Any inflammation in your eye? And really quick questions. But I really think that that's important now, and I've added that into this disease section for my patients' follow up when they're on disease. It helps.
I think that's such a great pearl, and I do the same thing, just like any vision changes, any redness to your eyes, any joint inflammation or joint pains that are new. So I think that's such a great pearl to remind the listeners.
I could not agree more. I think we sometimes can get a little bit, honed in on our one thing, right? So, like, oh, your joints are doing well. And maybe they wouldn't even think to tell us about their gut or their eyes, because if we're not asking, that I wouldn't automatically think, oh, what would that have to do with that? So, it's so important. The other thing that Kim, that you said that I thought was really meaningful was this kind of subclinical inflammation in the gut, because I can tell you, I totally feel like that with a lot of my patients, and maybe they haven't been yet diagnosed with ulcerative colitis or Crohn, but it's like I feel like something's brewing, and I know, I guess I don't know what the GI community is saying about this, but I know previously it was kind of like, "Oh, no, that's not really a thing," or at least I that was what my understanding was previously. But gosh, there's so many of these patients that you put them on a medication and magically their GI symptoms
Yeah,
go away,
yeah,
so it's like,
I agree.
how could that not be some kind of subclinical inflammatory response?
Yeah. And then I know this is a little bit different, but I feel like I have to add in the part of the IL-17, Amanda, kind of to your point of like, do they have something underlying? I just want to add in that the IL-17s, for those of you who don't know, we don't use those in GI. And really interesting, they have to be used really cautiously in patients who have IBD or who you might be wondering if they have that subclinical inflammation, because we know that these are associated with that increased risk of inducing or exacerbating or possibly revealing underlying IBD. So I just feel like I got to add that in, that that's one kind of difference of we don't have the shared mechanistic option for therapy with that class.
Kim, I do. I wonder about that as well. It makes me nervous in rheumatology sometimes
Yeah.
when I think about
Yeah.
that. Yes.
Absolutely. Well, it's always lovely when you put a patient on their very first medication and they do really well and their whole disease goes into remission. And my life and all of our lives would be so easy if that were just the case for everybody. Unfortunately, as we all know, and our listeners know, that is not what always happens. So, Kim, I'm going to start with you, but when you're thinking about a second line, after potentially kind of an inadequate response or intolerance to a first therapy, how does your decision making shift when you're choosing between a JAK? I mean, you already mentioned you don't really use IL-17s, an IL-23, shoot, a TNF. I mean,
Yeah.
especially when there's other autoimmune diseases that are starting to emerge.
Yeah. So again, my first thing is factoring in what those other autoimmune diseases are, whether they've been diagnosed or whether we're looking for that history to figure out what they might have. And so, for example, we use anti-integrins in IBD, vedolizumab, the common one. That's certainly not a medicine I'm going to go to second line in a patient who has these EIMs or associated other inflammatory conditions. UC and Crohn's are a little bit different for me. So with ulcerative colitis, I really do favor the JAKs second line if the patient is a really good candidate, especially again if they have axial or significant rheumatologic conditions. Again, they just work really fast. They work really well second line. Now, not to say I would not consider an IL-23. Again, this is the fun of medicine. It's really gray. It's not black and white. Now with Crohn's disease, we do see that the IL-23s work really well, even second line, not quite as well in UC second line. So that kind of is a little bit of a differentiator for me in IBD.
Wendy, what about you?
Yeah, that definitely, helps me with some patients I'm thinking of right now as well. So second line, so I know Jack's definitely, they inhibit that IL-23 as well. My one patient that had come from a GI that had been on the TNF and had been through biosimilars and had that severe flare, actually eventually had lost efficacy with Riz. And, she just must have had some kind of a really driving force of her inflammation. And with her, she was 50. She was also a smoker. So there were some comorbidities there as well. So we had some more, safety conversations. And, I started UPA, and she is to this moment continuing to do excellent. Also co-managing with GI. You scoped her. She has no active disease. And, she is so much better. She was a hairdresser, and she had just horrendous dactylitis and, synovitis in her hands. And then the scalp was just completely covered again. So, I like Uba. So that is definitely a great second line as well. If you started Riz first and they failed TNF.
You're getting me right to my next question, Wendy, which is how you talk to the patient about it. We have these it's easy to have conversations amongst ourselves. Well, gosh, it's actually sometimes not easy to have conversations. Sometimes I get really confused, when I'm talking to other specialists. But how do you talk to the patient about this? I mean, what does the conversation look like when you're recommending a medication that can potentially, treat multiple domains at once?
Right. You know, you can simplify it. You can easily say that these diseases are on the same axis with the gut, the skin, the joint. And that's exactly what I've been telling my patients lately. And it really does, I think, almost set a light bulb off with them as well. Of course, I always have my highway description. As we talked, like Kim said, the 5 lanes, but 2 of those lanes, those medicines are either not going to help you at all, like to cover all of these disease states, or one could cause, more concerns. And then just being honest with, any type of safety indications. I think patients, when they have gut disease and then they have skin and joint disease, they're miserable. Their quality of life, I've noticed, is severe. And that's tough for them as well. But just spending time, they have confidence in us. We've developed that confidence, just finding that spot that they understand.
Kim, do you do anything differently?
Yeah, I mean, I think very similar to Wendy, I try and kind of make it simple, just explaining to the patient that their immune-mediated inflammatory diseases, whether it's Crohn's and RA or psoriasis, that they share this common root. And essentially, the root is this overactive immune system that leads to excessive inflammation. And so when I start to then talk about meds, whether it's biologics or small molecules, just really explaining to them that because they have these shared inflammatory pathways, these drugs in this class can treat the inflammation across these different body systems. And so then it's kind of again like there are certain medicines I'm not going to recommend because it's not going to help your skin or it's not going to help your joints. And we really want them to understand that while their symptoms are in different places in their body, again, it's kind of the pathways we talked about in the beginning, these underlying pathways and cytokines and proteins are similar, leading to inflammation in different places. And I think that really helps without getting too much in the weeds of mechanism for them to kind of understand why we're driving them to that certain therapy. And then again, I know we talked about this so many times, but I love to try and connect with their other provider. And I think that really gives them a lot of reassurance if I'm able to reach their rheumatology physician or APP I love. They love when we're able to crosstalk and know that we're aligned with our same plan.
They do. They do. I've been doing a lot more of that as well. And it really is not a lot of time out of our schedules, but we're helping the patient and we're helping each other to be able to treat that patient better and at the highest quality we can. Yeah, that's great.
Yeah, I would echo everything that you guys are saying. And I think patients really look to us to be the experts, which is why it's so important for us to know how these therapies work, what they're indicated for, what they're not indicated for, what they could exacerbate. Um, because, at least in my experience, when I'm talking to a patient, if I give them five options, they kind of give me the deer in headlights look. I mean, I might say, there are these options, but this is the one I'm choosing for you because of X, Y, and Z. And these are the risks we need to be understanding of that. I get that you've smoked for, 20 years, but we got to quit now. Like, this is so important because and I think it also potentially then leads the patient to making better decisions potentially for themselves. Um, so I totally, totally agree. I'm gonna ask one kind of final question of both of you, which is, what does it look like to have optimal collaboration between a rheumatology and a GI provider that's co-managing a patient? Wendy, what does that look like for you?
Optimal, it's just really what we've already touched on. I think sharing notes is fabulous. We get so much information. We can scan those both into the charts. I'd mentioned earlier, loved getting the colonoscopy, reports into the chart as well. But then also the ease of communication, as Kim said.
Absolutely. And then, you know, Kim, from your perspective, what do you think GI clinicians wish that their rheumatology colleagues understood about IBD when caring for patients?
Ooh, that's a good one. Let me try and give a couple pearls there. I think the first one that's really important with IBD is we want you guys to know, and it's so important, even GI providers, I want them to know because I don't think they always know this, that just because IBD patients have symptoms, it doesn't mean their disease isn't under control. And so what I mean by that is we have a lot of data in IBD that patient symptoms and their actual objective disease activity do not align, particularly in Crohn's, right? And so patients can feel great and then we scope them and their disease is horrible. Or patients feel horrible and then we scope, we image, we do stool and lab tests. They're in this deep remission. So very often these patients have overlapping functional disease. So I think that's a really important thing to remember is don't automatically think like, God, the GI provider is not doing a good job. My patient still has symptoms because sometimes their symptoms are not actual objective active disease. So I think that's really the biggest one. And then I think the other thing that is unique to GI that I would pass on is yes, we use our serum biomarkers, our CRP or Ceterate. I'm assuming y'all use those, but a little bit different is we also use fecal calprotectin. And so I love fecal cal because this, for me, with patients with overlapping autoimmune inflammatory conditions, it is really sensitive and specific to the gut. And so it's a way for me to actually know is their GI tract in remission or not. And so I think that's an important differentiator just to remember again that said CRP can go up and down with multiple conditions, but that CalPro is so sensitive and specific to us in IBD.
And just a follow-up question now, sorry, because you told us that. Um,
Yeah.
and that's a stool test, correct?
It is a stool test. Yes.
Okay. And is it so because I've kind of seen those before where they're elevated. Is that
Yeah.
always specific to an IBD flare or could it be
So
elevated?
there are very few things that are going to cause it to be elevated. So it can be mildly elevated if somebody's on a PPI, but not typically the level we see with IBD. Um, the only other thing that really should elevate a CalPro is if they have an infection. But otherwise, if they really do have an elevated CalPro, I really start to think about, do they have IBD that has not been diagnosed, or do they have IBD that is not totally in remission and being treated the way it should?
Great. Well, thank you so much. Wendy, any final closing comments?
I really appreciate being a participant today on this podcast. Kim, you are wonderful. I wish I had contact with all my GI colleagues like you. I have already learned today things as well on the podcast.
back at you, Wendy. I wish we lived closer. And I want to close with that. I mean, I just encourage everybody to try and network with their other APP specialists around them, because I think it's the way that we all continue to grow as APPs and really the best patient care we can give to our patients.
Thank you so much. Well, as we wrap up today's Fireside Chat, I want to thank our guests, Kim and Wendy, for sharing their expertise and perspectives on the important intersection between rheumatology and gastroenterology. Conversations like this underscore the value of cross-specialty collaboration in managing complex inflammatory diseases and ensuring our patients receive truly comprehensive care. Just like Wendy said, I learned a ton as well, and so I know our listeners will too. I'd also like to thank you, our listeners, for joining us for this episode of Wrapcast, the official podcast of Rheumatology Advanced Practice Providers. We hope today's discussion provided insights you can apply in your own practice and spark new ways of thinking about multidisciplinary care. Be sure to subscribe to Wrapcast and explore our full library of educational content, including past episodes and upcoming Fireside Chats, available through Wrap's Content Room and Wrap ACE 2.0 mobile app. We look forward to continuing these meaningful conversations throughout 2026. Thank you to Gap for cross-posting this episode on their podcast, and thank you for listening. We will see you next time on Wrapcast.